Hi everyone. Okay, so we're going to talk about, this is a shorter chapter, chapter 18, about utility of clinical information systems. And we've touched a lot about clinical information system and how it's this living and breathing um, information system that we use to actively make decisions. So we're going to talk about the insider description of a clinical information system, explore knowledge dissemination and generation tools supported by CIS. So knowledge dissemination is spreading of knowledge, and generation tools supported by the CIS. So what kind of tools have come from that? Describe what quality assurance and clinical outcome measurements are and how they're supported by CIS. And explore evidence-based practice and translational research tools provided by CIS. All right, so as we talked about before, clinical information system, CIS, is a technology-based system that is applied at the point of care and is designed to support the acquisition and processing of information, as well as providing storage and processing capabilities. So what does that mean, Denise? Okay, so starting from the beginning, patient comes in, and as you are getting data and putting it in the computer, it's processing it to not just store the information, but to think one step ahead for you or with you. So somebody comes in and their blood pressure is crazy high, and you get the alert that the blood pressure is out of range. That is clinical support. And so it's going to prompt you to recheck the blood pressure. Now, of course, we've always done that, but it ensures that it gets done, right? In the same time, that prompt is already documenting that you were prompted, you rechecked it, and here are the two readings. And so you saved a bunch of charting and some thinking time so that you could think more about other things. Is this patient's pulse thready? Are they have a headache, chest pain? Oh, they don't? Great. Now I can talk about their asymptomatic malignant hypertension. So clinical outcomes and quality assurance supported by the clinical information system. So there's the ability to measure outcomes is enhanced or impeded by the way information systems designed and used. What does that mean? Okay. Your system for information has to be designed in a way that you are able to easily look at outcomes in a way that you see the true information. So for example, great outcome measure that we use in primary care, how many of your patients with the diagnoses of high blood pressure have a controlled blood pressure? Okay, so first of all, if you were doing this by hand, you're going to miss a lot of those diagnoses because there are 16 different ways you can diagnose hypertension. But because now we have ICD-10, it captures all the different ways that it's diagnosed, so that then your computer system can go and find every single patient of a certain age with that diagnosis and then see what their average last 5 blood pressure readings were and whether they're in goal or out of goal. So while many practitioners can paint a very good picture of the patient by using a narrative, that's great. Using this mode of expression in a clinical system without the use of a coded entry makes it difficult to analyze the care given or the patient's response. So the other thing too is it's really easy for me to just open up a chart. I know they have hypertension because it's on their problem list, and I know it's not controlled because I see their last recent blood pressures. Boom. But in the old days, you would get paper charts and you would have to go through and read the narrative. This wasn't controlled. That's one sentence in a bunch of narrative. So again, it's going to streamline the way you gather information. Free text reporting is helpful, but when you have a systematic way, you're going to have consistency of reporting from clinician to clinician. Here is an example. Murmurs. I think that is a really great way to be inconsistent. The way you chart murmurs, where you chart it, but it's really easy to glance back when you're not using free text, you're using some form of system where you go to the body system and you click on murmur, and then you can free text in there. Well, that's just going to streamline our cardiac assessment so that we can compare and contrast, as opposed to reading through the narrative in the chart. And what if the doctor forgot to, or the provider forgot to write about cardiovascular? What if the nurse who freehands likes to write about mental health at the beginning of her note as she goes down the assessment versus at the end. But if you use a flow sheet, then you know you're going to go to where the mental health section is, which of course we used on paper, but it's even faster and neater when you use it on the computer. So evidence-based practice, it doesn't take away from critical thinking skills. It enhances the way you make informed decision making. So evidence-based practice needs to be embedded in computerized documentation, providing both prompts for interventions and/or different questions based on the charted system. So really great example for evidence-based practice. All right, you got a patient, they're being admitted, they're overweight, they're sweaty, and they're not eating well because they're intubated. They're at risk for wound. Well, they're also at risk for a lot of stuff. And when you don't have these prompts, you're not going to remember everything. But it's going to be prompted because the computer is going to go down an algorithm and say, this person is it possibly at high risk for skin issues? Do you want to commit a Brady score? Based on the score, do you want to click these orders? How nice is that? And it doesn't take away your ability to be smart. Absolutely not. But it takes, it helps support you with all the tasks that you have to manage as a nurse. These prompts can be done by required fields that display only when the criteria is met, by pop-up boxes, or even printed reminders. So embedding evidence-based practice into nursing documentation is also increasing the compliance with JCAHO with their core measures, and that's like providing information on influenza and pneumo vaccines to at-risk patients, being prompted to give them their flu shot. I know that, you know, when I worked in the ICU, everyone got a flu and pneumonia shot when they came in, whether they wanted, whether they would get it in the outpatient setting or not, because it doesn't just protect them, it protects all the other staff and patients. And when we got into EMR, our numbers got better with that because we had that support, and then we were hitting our Joint Commission core measure. Creating an environment that encourages and expects professional development and learning needs to be consistent expectation across all levels of an organization. You can develop your EMR to not just be a patient care tool, but to be an organizational tool to help improve your nurses as well. You can embed training topics, educational topics within it, and that's really helpful. A lot of the institutions have implemented clinical practice councils that use information generated by the CIS to design clinical education programs. Okay, great example. Our blood pressure numbers aren't great, and part of it is patient stuff. So how are we going to improve patients' blood pressure? Well, let's teach our nurses how to improve our patients' blood pressure, because nurses are really good at doing that, and let's not just depend on doctors to do it. So first of all, let's make sure everyone's on the same page with how to check a blood pressure, because I've literally seen an MA and an RN check a blood pressure incorrectly. Maybe they're not waiting for the patient to calm down. They're checking their blood pressure when they run in from the lobby to be 10 points higher. I prescribe them a higher dose of antihypertensive and they bottom out at home. I don't have time to talk about sodium counting, but guess what? The nurse might. So these clinical practice councils are really great to figure out education programs, not just for patients, but for the staff. Meaningful use. The American Recovery and Reinvestment Act earmarked $19 billion to develop an electronic health information technology infrastructure that's going to improve efficiency. So we've talked about meaningful use. So summary. The CIS is a technology-based system that's applied at the point of care and is designed to support the acquisition and processing of information, as well as providing storage and processing capabilities. So incorporation of evidence-based practice and integration of a clinical expertise and best practices based on systematic research to enhance decision-making and improve patient care is going to enhance the system. So let's look a little more about clinical support.
Good morning, Bill. If there was one thing you would change to improve patient safety, what would it be?
Well, I think if I had to choose just one thing, it would probably be the effectiveness of clinical decision support software. So, healthcare is becoming increasingly complex, and we're asking doctors and nurses to do more with less, and we're asking them to take care of sicker patients and take care of them faster. And one of the ways that we think we're enabling this is through the electronic medical record and clinical decision support. So, the idea for the EHR is that it was going to reduce people's cognitive load and not increase it. And to the extent that clinical decision support supports that, that's the thing that I would like to see get better. So, for instance, one of the things that, the vision that we have for EHRs is that they're going to warn us against doing things that we want to avoid, and they're going to remind us to do the things that we want to remember to do.
But those things need to be tailored to the needs of the care facility, right?
Every healthcare organization has to become engaged in optimizing their clinical decision support. So right now, the problem of alert fatigue, I think, is a real issue in a lot of organizations, and I've heard some hospitals are even getting to the point where they're just simply turning it off rather than trying to fix it. And there are lots of things that you can do to make those, to make the alerts more relevant. But I think over time, what I would hope would happen is that clinical decision support will start to become context sensitive. So if a particular physician has overridden a particular alert for the same patient 3 days in a row, there's no need to keep presenting them with the same information over and over. And I think if we get to the point where the EHR is able to use a lot of the information that's already being captured, information about the patient's diagnosis, what kind of unit they are on, what sorts of problems are in their problem list, and start to use that information to decide what alerts to trigger and what warnings to fire. That will make it much more efficient and much less painful for the clinicians.
So in the meantime, what are some strategies that clinicians can implement with their clinical decision support systems that would make a difference today or tomorrow, as opposed to, with the next several versions of the software?
So one of the things that you can do is go to what's called a tiered alerting system. So a tiered alerting system basically sets 3 or 4 levels at which different sorts of interventions are applied. So an alert that might be a hard stop, you would only do that for something that is a high alert medication and clearly outside the dosing norms. A level back from that might be things where you require a physician to document why they're overriding an alert because it's still a significant issue. And as you get down to less serious drug interactions and things like that, you might have those things not be interruptive and only sort of off to the side and not interrupting the clinician in their workflow. It's primarily driven by a lot of the adverse events that we see at ECRI and issues of systems not supporting clinicians, warnings that should fire and don't, systems that have not incorporated specific checks that should be given, not looking for things that are out of dosing range. We have one of the issues that's on our top 10 list actually relates to this, which is people mixing up pounds and kilograms in the EHR, which can then affect how drugs are dosed. And some of the EHR systems do look for that and identify patients whose weight is discordant with other information that's in the system about the patient, like their age. So I think as we start to get better at using a lot of the information that we're already capturing in the EHR to improve clinical decision support, that will eventually make it more context sensitive and more relevant.
Clinical Decision Support Systems. Here's a scenario. Tim wakes up feeling sick and goes to the hospital to be examined. At the hospital, the doctor goes through the basic protocols by checking Tim's temperature, examining his throat, and asking him questions about his symptoms to gain some basic information about where Tim's sickness is coming from. After doing a basic checkup on Tim, there were a number of different things that could be wrong with him. The doctor also doesn't know if Tim's been telling the truth. Because of this, doctors sometimes have trouble getting a correct diagnosis out to their patients. This is where a clinical decision support system can come into play. These systems help doctors to narrow down the possible diagnosis to quickly and efficiently point to what the real issue is at hand. Clinical decision support systems are defined as an active knowledge system which use patient-specific data to generate case-specific advice. They are known to provide the entire clinical team with constant, reliable information about their patients to cut down on user error in a quick and efficient manner.
One major benefit from the use of CDSS is the reduction of misdiagnoses and medication errors. This is especially critical for infants and children in emergency situations. Calculations involving complex formulas are difficult for doctors to memorize, and errors can easily occur. More than 37% of pediatric medication errors are caused by inaccurate medication dosages. The CDSS allows for more accurate medication information and dosage calculators that can easily be adapted into a clinical setting without drastically changing the pre-existing work structure. The system can advise which treatments a patient should receive and the treatments they have already received. This allows for more accurate treatments and not duplicated treatments. The use of CDSS has significantly improved clinical practices in over 68% of trials. They allow for a more accurate analysis of patient-specific data in a more timely manner, making both the patient and the doctor's lives much easier.